Before that, I want to give you some demanding research pearls that, to me, every chiropractor should read and understand in order to inject the adrenaline type excitement into their clinical practice. I just collected this paper just this morning, my colleagues, in my search that came out of the British Medical Journal, September 11. But this paper is talking about persistent pain in post-surgical patients in the United Kingdom and what a problem it is. And we need evidence-based guidelines for the treatment of patients who have had back surgery and continue to have pain. You and I know that this is a big problem. We know that many papers show that 1 out of 2 people will have some relief, not well, but some relief. The other half basically are the same or worse post-surgically. I offer to you, as many of you know, that our technique is superior in treating the failed back surgical syndrome. Chow goes on to say, and I don't know if you saw this, but this was published in the Journal of Physical Therapy Science, August 2014. Flexion distraction technique is considered an effective intervention in addressing low back pain and disc heights in patients with chronic low back pain. Yes, my colleague, the physical therapists are practicing flexion distraction. They're publishing papers on it, as you see here. Chichi says that patients with chronic low back pain and low back disability should first consider spinal manipulation as conservative treatment. Don Murphy wrote this paper in JMPT clear back in 2009. He showed, now keep in mind what surgery does for pain and disability, about 50-50. Here's what he showed. Clinically meaningful improvement of pain and disability occurred pain in 79% of patients, and 70% disability was relieved at the end of treatment. And what treatment did they use? Flexion distraction. This paper just came out. The British Medical Journal Complementary Alternative Medicine, August 29th, last month. It is a survey of integrative lumbar spinal stenosis treatment in Korean medical doctors. It shows what was their treatment. Prone lumbosacral joint distraction method. Does that sound familiar to you? Penny wrote in BMC Family Practice March this year that the potential of acupuncture and chiropractic care as a tool to help manage pain and making acupuncture and chiropractic care more easily acceptable might lead to more satisfaction for patients and providers and provide important input to policymakers. That is, more and more conservative care in managing chronic low back pain. That would be you and me. What do surgeons say about this? Well, Spine Journal just published September 4th, just a week ago, that surgeons do not follow clinical practice guidelines before performing spine surgery. The most common modality that they used is drugs. Over 46% of we get opioids. No wonder we have an opioid epidemic. That is the way that they treat opioids and consultation. The majority of them never receive any other forms of conservative care. So I offer to you that as we develop guidelines, and they're out there already, the American College of Physicians, the American Pain Society, spinal manipulation is first-line treatment for back and radicular pain. Surgeons don't follow that. And here is the paper done by Zhang. What percent of primary care physicians even refer low back patients in the United States to conservative therapy? 10%. There's the paper. It's published. Julie will give it to you. There it is. I'm not making this up for you, my colleague. What will happen when that goes from 10 to 20%? And how can it do that? You and I can alter that by being the spine specialist that will determine the treatment, not go to the surgeon first for opioids. Come to the chiropractic board certified Cox practitioner who outlines the line of treatment and then determines the surgical necessity. Doctor, I offer to you, I don't know what it takes to open up the doors for what our profession has been preparing for 125 years. You feel the excitement? So what is the take of this discussion? What is it? Chiropractic is a great chance to grow as the best conservative treatment of back and radicular pain. Cox Spinal Manipulation is positioned with research and certified spine specialists to seize the opportunity. So as we move to a clinical round, we're going to talk about the very reason, the most powerful reason that you and I exist, and it's to treat this case: bilateral radiculopathy, spinal stenosis. Now, it doesn't get much more difficult than this. I think you'll agree as a clinician. I've asked you to note here at L4, L5, and 3-4. L5S1 looks good. We have a pretty good patent canal. I guarantee you that's well over 12 millimeters. So by the work of Stephen Eisenstein, that's not stenotic. But here's a different story. Ligamentum flavum here. Posterior disc bulge here. Cauda equina narrowed. L3, L4. Retrolisthesis here, about 8-10 millimeters. Ligamentum flavum thickening. Not as severe a stenosis here as here. Have you ever noticed that when you interfere with the lower lumbar spine and we begin to ask the thoracolumbar spine to make up for flexion extension, which it normally doesn't do, that we get this kind of degenerative change? So when we treat and we go to the instrument, I'd like to address this with you as well, please. Here on the axial view at 3-4, with the very, very large bilateral stenotic changes, narrowing of the osteoligamentous canals. What is this? Small synovial cyst in the right synovium of the L3-4 facet joint. What else do you see? Sedimentation sign. As this patient lies down, instead of settling into the dorsum of the thecal sac, they are floating. Positive sedimentation sign. Some thickening of the ligamentum flavum here. Certainly spinal stenosis. Some facet arthrosis, more marked on the left. And here the L4-5 level. Again, extreme posterolateral osteophytic and disc protrusion spinal stenosis. There's no room in the in here, is there? Here we are at L4-5. Bilateral stenosis, bilateral radicular pain. My case here, Dr. Ryan's case, L3-4, L5, L4-5, L3, L4 spinal bilateral stenosis, bilateral radiculopathy. I'm holding here the L3 spinous process. I move to the taut point, and please stay with me here. I apply a very gentle force. And when we start, this force will be approximately 8 pounds. So at the outset, therefore, with my hand here, I move to the taut point. Having done this a few thousand times, I can tell you this is 8 pounds right here. That's how I start.